They are awesome if the patients are staying on top of taking care of these, though. Ventilation does require an intact rib cage. We have two sets of intercostal muscles. Your intercostal muscles are in between each rib. We actually have internal and external intercostal muscles. Our internal intercostal muscles helps with expiration, where our external intercostal muscles help with inspiration. So it's backwards on those. Okay, make sure you guys don't mix those up. You have 12 pairs of ribs. 1 through 7 are attached through the sternum directly. 8 and 10 are attached through rib 7 via cartilage, and then 11 and 12 are floating. Are the floating ribs. Okay. If you guys can kind of look at the picture of the ribs here and kind of picture this in your mind, the diaphragm is actually attached anteriorly to the xiphoid process of the sternum. And then posteriorly, it kind of lands right around T8 or T9 in the back. The diaphragm is controlled by, the diaphragm is the major muscle for breathing. Okay, it's controlled by the phrenic nerve. The phrenic nerve runs off of C3, C4, and C5. We want to make sure that we definitely don't damage that area of our neck, because we could definitely stop breathing real quick. But it is controlled by the phrenic nerve, and we'll talk about that more here in a sec. Okay, gas laws. Again, I'm not going to spend too much time on this. I am going to mention a couple things about these. All right, Dalton's gas law boils and Henry's gas law. We call it Dalton's gang, Dalton's bubbles, and Dalton's gangs, Boyle's bubbles, and Henry Heineken's. Okay, those are just kind of the ways to remember it, and I'll kind of point those out to you as we go on here. But please make sure you guys are watching those videos. They do a great job explaining this. So basically, Dalton's law is Dalton's gang. Think of it as a gang. We're trying to get all the sums of every partial pressure of whatever's in our air. Okay, so oxygen makes up 21% of our atmospheric gases. Okay, so the partial pressure of oxygen is 21, right? Nitrogen is 78 to 79%, so the partial pressure is 78 or 79, whatever that number is. I think it's like right in between 78.5 or 78.6, something like that. And then CO2 makes up the remainder, right? So CO2 is right around, I think it's like truly like less than 1% in our atmosphere. So we just take the sum up. Dalton's law will basically be you add up all those, and that's the sum of that gives you the partial pressure of gives you the actual pressures of the atmosphere. Boyle's law is has to do with lung expansion, I guess is the best way to explain it, and some a little bit of interthoracic pressure. Basically, what Boyle's bubble says is that the smaller the container or the smaller the bubble, the more pressure is in there. Okay, the larger the bubble, the decreased pressure. The way I remember this, and I know this is silly, but I'm going to put this in your head. If you guys are blowing bubbles and you guys blow those real big bubbles, they're easy to pop, right? They pop real quick. However, those little smaller bubbles can really kind of travel quite some time, because they do actually tend to have more pressure inside them. But anyways, what we're talking about this with the lungs is that as we exhale, as the lung collapses, the space becomes smaller, right? So because the space is becoming smaller, the pressures are becoming higher than the outside air, right? So this forces us to blow our air out. Okay, I'll say that one more time. As our lungs start to collapse, we have taken that nice deep breath in, we have hit all of those stretch receptors and whatnot. The signal has been sent up to our brain in order to start the process of exhalation, right? So as we exhale and our lungs are getting smaller and smaller and smaller, the pressure inside is getting higher and higher and higher, which forces the air out. Okay? Now, and vice versa, as we start to breathe in, the expansion of lungs, the decrease of the lung cavity pressures actually forces the air in. Okay, so it's all that positive and negative pressures. Okay, that's why when you guys bag somebody, it's called positive pressure ventilation, because we're positively adding pressure into the cavity. Okay, and then Henry Heineken law, we call it Henry Heineken's because it's just like when you guys pop open a soda or a beer or whatnot. If you guys are old enough to drink, it's how the release of gases are dissolved in the liquid. And again, I think that you guys looking over those videos, they do an excellent job for entry-level paramedic explanation on that. There's a ton of stuff on YouTube on this and on Khan Academy as well. You guys can look that up. And you guys will definitely need to know these specifically if you guys ever decide to go to or take the flight paramedic course. Okay, gas terms, I'm not going to go through these. You guys can read through these on your own. What I do want to come to is the difference between SaO2 and SpO2. Okay, so the only way that we can find the saturation of oxygen in our arteries is through blood draws, okay, or ABGs, right? You guys will talk about arterial blood gases later on this semester. Joy Cherry is going to be doing a recorded online video for you guys on that. She does a very good job explaining ABGs, okay? However, you guys know SpO2. SpO2 is your pulse oximetry. You guys don't need to know. This is just for general knowledge. But how does that pulse ox actually get a percentage? Well, how it does that is it takes the hemoglobin that is saturated with oxygen, okay, and then it divides that by the hemoglobin that is saturated with oxygen plus the hemoglobin that is desaturated, the deoxyhemoglobin. They divide that together, and that's how you guys get your pulse oximetry percentage. The difference between hypoxemia and hypoxia, you guys can read over that. Please make sure you guys know that for your exam and National Registry. Okay. When we're talking about feedback loops, guys, is breathing a negative or a positive feedback loop? I'm going to tell you right now, it is a negative feedback loop, and I'm going to have you guys find out why that is. Okay, I'm not going to explain that to you. I think the book does a very good job at that. Make sure you guys look up feedback loops, and you guys can start reading up on that. There's only so many positive feedback loops in our body. There's really only a couple positive feedback loops in our body. Well, now that I think about it, there may only be one positive feedback loop in our body. I have to look that up. I do know of one definitely. But make sure you guys look that up. If you guys have any questions on that, feel free to email me. I can go over that with you. Okay, surfactants. Surfactant is basically a lubricant that we produce to help our lungs not stick to the inside of our chest. So that when we are taking those nice big deep breaths in, we have very good compliance. Our lungs are not rubbing up on the inside of our rib cage, okay? And it also helps them from preventing from actually the inside of the lungs from sticking together, okay? So we want the compliance to be good, and if compliance is good, we have a decrease in tension, allowing efficient expansion. That's exactly what we're looking for every one of our patients. Pulmonary circulation is circulation direct from the heart to perfuse the body. Remember that the veins in the pulmonary system are the only veins that carry oxygenated blood, where the pulmonary arteries are the only arteries that carry deoxygenated blood. So let's take a second here and let's review some stuff based on the blood flow through the heart. Okay, you guys will need this for cardiac anyways. So we got the superior inferior vena cava. The superior drains the blood from the brain or from the head. The inferior vena cava collects the blood from the rest of the body. Both those veins drop or expel the blood into the right atrium. The right atrium contracts. It goes into the tricuspid valve. It goes through the tricuspid valve into the right ventricle. The right ventricle goes from the once it contracts, it goes into the pulmonary pulmonic valve and into the pulmonary artery. Okay, so again, the pulmonary arteries are the only arteries that carry deoxygenated blood. Those pulmonary arteries lead into the right and left lung where oxygen exchange occurs. Okay, so now we have oxygenated blood. That oxygenated blood is carried back through the pulmonary veins. You have two on the right and two on the left. 2 pulmonary veins on the right, 2 pulmonary veins on the left. The pulmonary veins are the only veins in the body that carry oxygenated blood back to the heart. That drops into the left atrium. From left atrium, it goes into the mitral valve, goes through the mitral valve into the left ventricle. Left ventricle contracts, goes through the aortic valve into the aorta. Hopefully we have good adequate perfusion pressure in our system so that we can get perfusion all the way down to our big toe. Okay? Bronchial circulation, arteries branch off the arteries branch off the aorta and perfuse lung tissue. They use the veins of the pulmonary circulation to return blood. Just what I just said, okay? However, here's the deal. Let's talk about this for a sec. Anytime that we have the arteries, anytime that we have like a PE, let's say we have a PE, okay? Let's say we have a clot in the lung, okay? Circulation past that clot, right? That clot's sitting there. It's not letting the tissues around that clot get perfused, and anything past that clot get perfused, right? So what the body does naturally is that the arteries will constrict around the areas of the PE, and it will dilate in other areas of the lung in order for the blood to get good, adequate oxygenation. So if I have a pulmonary embolism, all the blood that is kind of going towards that area will be shunted through the arteries, and the arteries in the pulmonary system will start to dilate so that it can take on that extra blood flow that's not going to that area of the lung and take it to another area of the lung in order to try to get perfused. The body does an okay job with this, right? However, it's not as efficient as if we did not have a PE, obviously. So we'll talk about PEs more when we get into disease processes. Respiratory volumes we're going to talk about. These are going to become kind of important once we kind of start getting into mechanical ventilation with the doc's speech or doc's lecture that he's going to give on mechanical ventilation. I'm going to go into these just a little bit for you guys. It is important, okay? But I think that if you can get the good understanding here, this will really, really get fine-tuned when you guys listen to the doc's speech. This next slide is the lung volumes and capacities slide. This is a very famous chart that you guys will see, specifically you guys that are wanting to become flight paramedics. You guys will get to know this chart very well. It talks about lung volumes, okay, and how we can increase or decrease lung volumes based on our own personal how do I put this, actions, okay? So I'm going to go into each one of these kind of individually so that this will kind of all make sense. But for now, I want you guys to do something for me. I want you guys to realize that for your average adult male, the lung volume maximum, without a doubt, before we're going to start causing serious damage, is 6 liters, okay? And for the average adult male, our tidal volume is right around 500 cc's, okay? All right, so inspiratory volume, reserve volume, okay? This is the amount of air that we can forcefully inhale after we have increased tidal volume, okay, or after we have produced tidal volume. Now again, tidal volume was 500 cc's, okay? The deepest breath possible, though, that we can do is about 3,000 mLs or 3 liters, okay? So I breathe in naturally, but I try to breathe in, I forcefully breathe in, trying to take in that nice deep breath. The most I'm going to get is right around 3,000 mLs, okay? Naturally, okay, that's just us. This is not with mechanical ventilation, all right? Naturally, I could do about 3,000 mLs. However, my expiratory reserve and residual volume, my expiratory reserve volume is basically the opposite of inspired, okay? It's the amount of air that I can forcibly exhale after I have already done my normal exhalation, okay? That's right around 1,200 cc's, okay? So my inspiratory reserve volume is at 3,000 cc's. My expiratory reserve volume is at 1200 cc's, and my residual volume is the amount of air that is left in my lungs after ERV has been exhaled, which is also another 1200 cc's. So let's talk about this for a sec. I'm able to breathe in 3 liters of air, 3,000 mLs of air. Okay, the most I can breathe out at one time is 1200 cc's, because the other 1200 cc's that I have, or another 1200 cc's that I have, is stuck in there in order for me to maintain all of my anatomy to stay open. So that only comes out to 2400, right? So I got 2400. I took in 3,000, but I only pulled out 2400. Okay, and I technically really didn't pull out 2400. I only pulled out 1200 of that 2400. But for conversation's sake, let's say we blew out all 2400 cc's of that. Okay. Your tidal volume is normally 500 cc's, right? That 500 cc's is used for gas exchange. So if you guys are doing the math now, right, we got 1200 plus 1200 plus 500, we're at 2900. We still got about 100 cc's left over. Where the hell did it go? Well, that 100 cc's, it's really about 100, 150 cc's, but is known as dead space. Dead space is there in order for us to make sure that we that air is not involved in gas exchange whatsoever. It never sees the alveoli, but it keeps that kind of air in our trachea before we take our next breath, so that we know that it's filtered, it's humidified, it's warmed, it's ready to rock as soon as I start breathing in that normal amount of air. Okay. So again, tidal volume is the amount of air inspired during a normal ventilation. That's right around 500 cc's. Okay. However, we get tidal volume based on ideal body weight. We don't spend too much time on ideal body weight in the class. Okay. But I want to present this now so that when you guys do have the lecture for the ventilators, you guys will be able to kind of make some sense of this. So here are, when we're calculating tidal volume, here is the formulas for ideal body weight. Okay. I'm not asking you guys to commit these to memory. I'm just asking you guys to look these over and make sure that you kind of understand this equation based on or before you guys take the lecture for the mechanical ventilation by Doc. So really what it comes down to is we got a 5'6" male weighing about 90 kilograms. Okay, we're going to take the 6 times the 2.2 plus the 50 times the 8, which equals 506 mLs, which is the normal tidal volume, which we already said. Normal tidal volume for an adult male is right around 500 mLs. Dead space, again, no alveoli, no gas exchange whatsoever. This is just air that's there to make sure that we stay moist, filtered, with the next incoming breath, and it's usually found in the trachea. Okay. When you guys are bagging somebody, however, though, you guys have to compensate for that dead space. So I know that you guys have definitely practiced bagging on mannequins. If you guys have, I know some of you guys are already in the field. You guys have already bagged patients. For most of you, I'm pretty sure all of you guys, or I haven't met all of you guys yet, but I'm pretty sure all of you guys are in the field. When you're bagging that patient, it takes a little bit more extra time than it does on those mannequins in order to achieve chest rise, right? And that's because we're making up for that dead space, okay? So you're more than likely going to be squeezing most of that bag in order for you guys to get that adequate equal bilateral chest rise while you are bagging your patients, okay? Minute volume, you guys will need to know. Minute volume is tidal volume times the ventilatory rate of your patient. So we have that 506 mLs, which was our tidal volume, and we'll say our patient's breathing 12 times a minute. That comes right out to 6 liters per minute. Okay.